Hello everyone, welcome to NG's Corner for Nurses. Hope all of you are doing well. In the first part of this series, we have covered the basic concept of ECG and the action potential in cardiac muscle. In this session, we will cover the ECG waveforms in details. Let's start today's session. We know that the ECG records electrical impulses from the heart onto graph paper, and these electrical impulses are recorded as waves or deflections. And normally one heartbeat is recorded as a grouping of waves called PQRST deflections. The P wave represents depolarization of atrial muscle cell. First deflection of each cardiac cycle, depolarization of both atria. First half of each P wave represents depolarization of right atrium, and second half of each P wave represents depolarization of left atrium. Each P wave precedes each QRS complex. The amplitude is 2 to 3 millimeter height and duration is 0.06 to 0.12 seconds. P wave is gently rounded, normally positive and not peaked or notched. There may be some abnormalities in the P wave, like peaked, notched or enlarged P wave indicate atrial hypertrophy, COPD, pulmonary emboli or heart failure. Next, coming to PR interval. PR interval represents the time of transmission of electrical impulse from the atria to ventricle. The location beginning of P wave to beginning of QRS complex. The normal PR interval ranges from 0.12 to 0.20 seconds. There may be abnormality in PR interval. Maybe short interval which indicate junctional arrhythmias or pre-excitation syndrome, and prolonged PR interval may represent heart block or conduction delay due to digoxin toxicity or slowing related to ischemia or conduction tissue disease. QRS complex represents depolarization of ventricular muscle cells. Q wave is the first downward or negative deflection precede R wave. R wave is the first upward or positive deflection, and S wave is the downward or negative deflection that follows R wave. The location of QRS complex includes, it follows the PR interval. The amplitude is 5 to 30 millimeter height. Duration is 0.06 to 0.10 second or half of PR interval. And the configuration, the QRS complex is subdivided into specific deflection or waves. There may be abnormalities in QRS complex. The pathological Q wave or the deep white Q wave may indicate the myocardial infarction. Notched R wave indicate bundle branch block, and missing QRS complex indicate AV block or ventricular standstill. Next, coming to ST segment. It represents earlier phase of ventricular repolarization. It extends from the end of QRS complex to the beginning of T wave. The point at which the ST segment joined QRS complex called the J point, and the XT segment is usually isoelectric or on the baseline. Slight displacement of the ST segment above or below the baseline may represent a normal variant. Greater degrees of ST segment displacement may indicate ischemia, injury, strain, drug or metabolic effects, stroke and many other conditions. T wave represents the end of repolarization of the ventricles. It always follows the QRS complex, normally oriented in the same direction as the QRS complex, and it's slightly rounded and asymmetrical and usually exhibits a smooth takeoff from the end of the ST segment. There may be the abnormalities in the T wave like tall or peaked T wave or inverted T wave. Tall, peaked or tented T wave indicates myocardial injury or hyperkalemia, and inverted T wave indicates myocardial ischemia. QT interval represents the total time required for both depolarization and repolarization of the ventricles to occur. It measured from the beginning of the QRS complex to the end of the T wave. The normal QT interval ranges from 0.35 to 0.45 seconds. The abnormal QT interval includes prolonged QT interval, which indicates prolonged ventricular repolarization or congenital prolonged QT syndrome, and short QT interval indicates digoxin toxicity and hypercalcemia. U wave is a small deflection following the T wave. Its significance is unknown, but it may represent further repolarization of the ventricles. The U wave is usually observed in the chest leads, and it may be upright in patients with hypokalemia or inverted in patients with ischemia or left ventricular hypertrophy. Now the question may arise, where is the atrial repolarization in ECG? The waveform representing repolarization of the atria is usually not seen on the ECG because it is small and usually buried within much larger QRS complex. The next part of this topic will coming soon. If this content is useful for you, then please put a like and share it with others. And for getting more videos like this, you can subscribe my YouTube channel NG's Corner for nurses. And for any suggestions or for any queries, you are most welcome to comment. Thank you for watching.